Welcome back. We're going to get started, if that's okay. I'm going to graciously skip the introduction. So this is the question and answer session for macular degeneration. And we're going to take questions from all of you. And if there are none, we will ask Dr. Williams and Dr. Els the questions. So I'd like to also introduce Dr. Els, who's going to help us in the Q&A today. So please feel free to ask whatever you want.
So this is your opportunity to ask us the questions. And so while you're thinking of the first question, I will get Dr. Cranny to answer a couple of questions. That'll maybe get the ball rolling, and then we'll go from there. So. Let me just ask Dr. Cranny, when you see a brand new patient with wet macular degeneration and you're going to start treatment, and we know that there's 3 drugs, how do you choose?
That's a tough question. The choice of drug is based on multiple factors. And the biggest factor is based on effectiveness. So we always want to pick the drug that works the best. In our studies, our literature, our experience shows that the 3 drugs, Avastin, Lucentis, and Eylea, have a similar effectiveness. They are pretty much cousins, if you will. There are subtle differences between them. Their effectiveness is slightly different in certain situations, individual responses. But by and large, we think of them as similar medications. So for me, I tend to use additional factors to help us decide. So safety would be the next factor in the decision-making process. So we always worry about systemic side effects. And we know that these VEGF medications are putting patients at risk for embolic events, heart attack and stroke. So if the patient has a higher risk for such a problem, like if they've had a recent heart attack or they're a recent stroke or they're medically unwell due to cardiovascular abnormalities, I may choose a medication in keeping with trying to reduce the systemic dosage. And so some of the medications are absorbed into the bloodstream more so than the other ones. So for example, Avastin has a longer systemic effect than the other ones. So you may want to choose Lucentis, for example, in that scenario. The biggest driving force, in addition to effectiveness and safety, is cost. And it's always the elephant in the room. We never want to choose based on cost, but we are a public health care system. We all pay for the drug collectively. And so it's become a social responsibility in choosing wisely. The cost of the drug is an expensive treatment. So I do present that to the patients and say they work similarly, their side effect profile is similar, but some of them cost more than the others. And is that important to you as a patient or not? And if it's not, then sometimes I choose the less expensive one. If it is, and if it's covered by the healthcare system, like Lucentis is currently covered, then we choose that one. So those are the main reasons, the main factors: cost, safety, and effectiveness, Jeff.
Yeah, sure. So the question is how do you get into a research trial? These are things that are very dependent on a narrow consideration, and most of the time they have to do with new patients getting the treatment for the first time with a new drug. So it generally doesn't apply to people who have been treated many, many times, okay? But the most important thing is to kind of stay in touch with your doctor and, just ask that question: are there any research trials that might apply to me? Okay, and most of the time the answer to that is probably going to be no. But what we're looking for is for the next generation or the new treatments, they generally have to be people who have never been treated before, and you start fresh with this new drug and you see how it goes. So, okay.
Oh, sorry.
You-
In the case of wet macular degeneration, why does body starts producing those blood vessels in the eye after a certain age? Is it something related with the immune system, or what are the main causes of it?
That's a really good question. I'm going to ask Dr. Cranny to answer here with his expertise. We'll just repeat the question. Why does the body make new blood vessels anyway?
It's a very complicated question, actually. Basically, the formation of blood vessels is a balance between the factors that stimulate it and the factors that regress it. And so the key factor that stimulates blood vessel formation is a hormone or a growth factor called vascular endothelial growth factor. So in certain diseases, that growth factor is increased, it's upregulated. And when that happens, the body then responds by growing blood vessels. So certain disease states or environments in the body stimulate that growth factor, like diabetes, for example, or when people get retinal strokes, like when the blood vessels block. And in macular degeneration, when there's degeneration of the macula due to thinning and aging and deposition of drusen and evolution of pigment, the vascular endothelial growth factor concentration increases in the milieu and triggers the blood vessel growth. So that's why it occurs. The good question was, is there prevention strategies instead of treatment strategies? And there are some good prevention strategies, and I'm going to ask Dr. Els to help highlight some of them. There's some very good ones, so that I can utilize her capacity and intellect too.
It's like, tag, you're it. I think, were all of you in the other session? Or any of you? You were in the, yeah, okay. So I just didn't want to repeat myself. But, what we talked about on the other side was that we do have very, very good science or evidence that shows us that we can slow the progression of disease by some preventive strategies, which include wearing sunglasses and having a diet that's rich in nutrients and vitamins. So we know that these things do decrease the progression of the disease up to 25-26% over a 5-year studied period. So it's very significant. We also do know that making sure that the rest of our body is healthy will also help our eyes. So our eyes are part of our system. So we know that if our blood pressure is well controlled, if we have diabetes and age-related macular degeneration, if our diabetes is well controlled, if we have high cholesterol or an abnormal lipid profile, if we can balance the cholesterol in our bodies with medication or diet, these things all make a significant difference in the progression of disease. So they're not super fancy, but they're incredibly important. You're going to ask me another political question.
No,
You're
won't.
like putting me on the spot.
You've talked about all the good food. Are there any foods that you would suggest that would be negative? Like real fatty foods? Or,
Right.
or
Yeah.
whatever?
Yeah. So again, those things have not been studied in a really scientific way, but I think that we know from our cardiology colleagues and internal medicine colleagues that diets that are high in fats, especially saturated fats, and make our cholesterol high and predispose us to hardening of the arteries and and clots and things like that. So, we have evidence from other areas of medicine that suggests that these things are not good if we're overweight. This hurts our body. It hurts all of our systems. It hurts our gut. It hurts our heart. It hurts our eyes. So all of those things we know make our AMD potentially increase the progression of our disease.
On the subject, just carrying on with the matter of diet, what was served here today was Black Forest ham. It has nitrates. Should we eat? How careful should we be about nitrates and the smokies and that sort of thing?
Yeah, I'm surprised that I didn't get asked that on the other side. Yeah, because we recommend fish, and now, so I think we just have to be aware of where the fish and meat and things come from, and try to balance what we know are byproducts of the things that we eat. And it is complicated. It's complicated, but we still have to eat, and we have to enjoy our food. That's very, very important. It's one of life's great pleasures is food. But I think we can do it in a way that's mindful and healthy, and will make a difference not only to our eyes and our AMD, but also to our heart and our brains.
I have received injections in both eyes since 2011, and the last 3 times it's been every month. And then this last time, even though the one eye is not better, he said we cannot continue this because of complications, and like you mentioned, heart. And he's asked me to come back this time. He's prolonged it to 6 weeks. But I don't know if it will continue on for me or not.
So maybe there's a couple of questions I can pull out of that comment. One was, when do you stop or when do you slow down? Would be one question I got out of that. And the other one was, what I think I heard there was, is if you are not getting better. Is that the other part of the question? Yeah, what to do? Yeah. So yeah, we know that this is a chronic condition, and we know that the ongoing therapy sometimes results in a stabilization of vision, and often a stabilization of the growth of the blood vessels and so forth. But sometimes the vision continues to go down for other reasons. So the dry macular degeneration, as I said, keeps grumbling along. And sometimes you reach the point where we don't feel that the treatment is actually helping anymore, that maybe the safety of doing another injection is now a higher consideration than what's happening in the eye. And so then you decide, well, if we slow down, let's see what happens. Okay, so that may be a consideration, I think, in someone like yourself. So we only really want to continue the therapy intensively, like every month, when we know that it's making a difference or protecting your vision. But when you've lost it, sometimes you have to admit, okay, we've gotten this far down the road and it's not making any difference anymore, and so you slow down or stop. Okay?
My main question was answered by Dr. Williams this morning. It's regarding the fact I have macula, and it has taken the vision out of my central vision almost completely. But my question was, and over the last number of years, my vision in my peripheral vision is getting worse, and I'm wondering, will that extend to the outer part of my peripheral vision as well, or will it stop at some time beyond the macula?
Yeah, that's a good question. So it's extremely rare for the eye to go totally blind. It has to have some complication or something like that. But the dry macular degeneration generally happens in the macula, in the center. But we know that there are signs of the same process happening in the peripheral retina. So you can notice a little decline over time. It tends to be slow, but I would say it's almost never total, that it goes completely blind all the way out to the periphery.
But it is a slow progression.
It is a slow progressive. Unfortunately, there's an aging component to that, and that just there's a certain inevitability. Yes.
Well, I'm certainly in the aging part of that.
Yeah, we couldn't tell.
Thank you very much.
Yeah, you're welcome.
Yeah, my question is regard to Visidyne procedure. It's been around for years, and I'm interested to know, is it being used regularly as it did half a dozen years ago, or not as regular? And if so, is it because it's more risky?
Maybe I'll just quickly answer it. We don't use it anymore like we did 10 years ago because the advancements that have occurred with the new drugs, Avastin, Lucentis, and Eylea, the outcomes, the visual outcomes in patients who receive this therapy is much better than the patients who received Visidyne. So once these drugs became available to us, we switched.
Dr. Karani, because I've had the detached retina surgery, is one more susceptible to things like macular degeneration with that, or does it have no bearing on it?
That's a really good question. I would, just out of experience and sort of professional opinion, say that they're not related. The retinal detachment usually is caused by a hole or a tear in the retina, and there's a mechanical separation in the retina from the back wall of the eye. So the reattachment surgery is basically an effort to push the retina back into its place and seal that hole. And so I don't think that would necessarily trigger macular degeneration. Now, retinal reattachment surgeries and retinal detachments do trigger various changes in the eye, particularly inflammatory processes and sometimes changes in the circulation. So on rare occasions, the inflammatory and circulatory cascades might change the VEGF levels that we talked about. Occasionally, we do see patients who have had retinal detachments then develop blood vessel proliferation. But I don't think it's a coincident, not a causation.
When it comes to family history, I think I may have inherited a gene or a predisposition from my mother, but I only have sons, and I'm wondering if you know if my sons would be as at risk as if I had daughters.
Great question. I'm going to ask our female star doctor to answer that one.
There is so much work at the moment in genetics of AMD, and it started about 6 or 7 years ago. I can remember at ARVA, one of our more basic science meetings, when the first presentation for a gene that was related to inflammation was presented, and it was like the buzz. You could hear it, you could feel it. So we're learning so much more every year about genes, but we have a long way to go. So that's a graceful way of saying I don't know to your question, but I think we do know that the genetics are complicated. There's more than 7 different mutations that have been isolated, and their transmission is. I don't think it's on the X chromosome. I think that it can go to the Y or the X chromosome. So I would say that probably males and females are at risk for the inflammation associated with the disease in AMD.
My question is, I was diagnosed with AMD last year at age 61. My mom was diagnosed last year at age 88 with AMD. And my question is about the naming. Age-related macular degeneration. I'm wondering if we are limiting the thinking and the imagination and the research around macular degeneration just by naming it an age-related disease or phenomenon.
So we completely agree about the age challenge there. There are younger patients that get it. 61 in your situation, we would say that's young. In the past, we would define 65 as the cutoff for age diseases. We've quickly realized that there are 50-year-olds that present with early age-related macular degeneration. And so we agree that maybe the definition of age could change there. On the other hand, 20-year-olds don't generally get it. So there is a large age-related and environmental factor beyond the genetics that we've touched on earlier. So it's not only age-related, there are other factors too. The problem that actually we have with the term age-related is more with the regulatory agencies and the coverage of drug access. And so because they're defined as age-related diseases, often the pharmaceutical products are not available to patients who are younger than 65, like in our situation here. So Lucentis is provincially funded when the patient is over 65, and it's a bee in all of our bonnets. And we can't seem to change that because that's how the studies were categorized, over 65. That's how the regulatories have made their agencies have made their rules. And so it's limited our progress, I would agree, and it's limited our ability to provide access to patients that are younger than 65. So it does need to change.
My question is, can the cumulative effect of number of eye injections affect the progression of the macular degeneration, or can they be also a factor in creating some other eye problems?
There aren't any. No, don't worry about it. So that's a really good question because I think we're going to answer it in two different ways. So one would be, does it affect the macular degeneration itself, and are there other things that could happen in the eye that might be consequences? So we'll deal with the first one, the condition. So when the studies first started in this condition, with the injectable drugs, that goes back to about 2004, 2005. Some of those patients are still undergoing therapy to this day. And there's a few of them even have been monthly now for getting on now close to 10 years. So we're up 120 plus injections there. And I haven't had that experience myself, but I know one researcher who has patients in that category, and they say it's just kind of amazing that you look at the eye and it doesn't look any different than the day you started with the first injection. So there doesn't seem to be any effect from these multiple injections. Having said that, we do kind of wonder, could we be generating glaucoma? We don't seem to be seeing cataract, but what about glaucoma? I think that's a bit of an open question right now. I think that we follow these patients so very carefully now. Never before have we ever seen so many people monthly, that we actually pick up some of the people who are now getting glaucoma also. And so now we're scratching our head. Did we cause that glaucoma, or did they just develop glaucoma anyway? And so that's going to be an area of research. I think that one of the things we're going to be looking at here in Calgary with some of our colleagues to see is if we can tease that idea out. But so the answer to the question, I think, is basically no, as far as we understand right now. But we're always kind of on the lookout for that very problem. And the final thing I would say to that is just that we're always having in the back of our mind, every injection carries with it a tiny little bit of risk. So, if you get an infection, and it can be devastating if you get an infection, then we really want to make sure that we were doing that injection for a good reason in the first place.
Dr. Williams, if you have glaucoma, can that be a predisposition for macular degeneration? And I have sort of one other question too.
Okay, so the reverse is if you have glaucoma. So again, as far as we know, the answer is no. We do sometimes have concerns about doing injections on patients who have glaucoma because we know that we're raising the pressure. Every time we squirt that drug in there, the pressure goes up a little bit. And we kind of worry about, well, if this eye already is sensitive to bad glaucoma, could we be making it worse? And so sometimes we actually draw a little fluid off when we're in that situation just because we're that worried about the pressure. So we do kind of do some special measures sometimes when we're concerned about that.
And my other question, I've been told I have something called pigmentation syndrome or it's not a pigmentosis, but
pigmentary glaucoma?
No,
No.
Dr. Douglas said pigmentation syndrome or something. Like there's flecks of the pigment or something coming off. So is that related to something further down the road, perhaps?
Not to AMD or the retina condition, but there is a pigmentary glaucoma, so you can get excess pigment buildup in the angle, the drainage area of your eye, and in essence clogging the drain and raising the pressure and causing glaucoma over time. So there is such a condition. So.
Could we talk about excessive computer use? So for the last few years, those of us who are still working are working 8 hours plus a day on a computer nonstop. And I know that you don't believe there is a correlation between AMD and excessive computer use. However, over the last 3 years, whenever I've been on vacation for a month, I come back and there is no fluid buildup. I'm back at work, 8 hours on the computer. Within days, I go back in and my fluid has gone back up. So I feel there is a correlation.
I can understand that. We're in big trouble because we're going to electronic medical records, so we're looking at a computer all day as well, just treating patients with this condition. So believe me, if we think that there's a concern there, I don't think that we're doing the right thing there either. But I do believe that there are other factors as to why the fluid builds up as well. It's not simply just how you use your eyes. It's your physical condition, your hydration, your activity, your stress levels, these other things that have effects on the body and on the blood vessels can have subtle effects that then become apparent in the eyes. So it's not necessarily just looking at the screen. Being on vacation is, I routinely prescribe Hawaii. I write it down and say, here you go, and it works, yeah.
Thank you, and thank you for the day and for the doctors being here. It's wonderful. You've mentioned high blood pressure and other factors. What about low blood pressure? Is there any correlation?
Yeah, every time we get a question we don't know the answer to, we ask somebody else here. So I don't know of anything about low blood pressure being a factor. Do you guys know anything? No. There are conditions actually that happen to the optic nerve, not so much the retina, but the optic nerve, where if your blood pressure goes very low in the night for some reason, that you can have occlusions, or what we call an optic neuropathy. It has to do with very low blood pressures. So that can happen, but it's not really a retina condition. It's more of an optic nerve condition. So.
I just want to mention the Amsler use of the Amsler grid. For one eye, the squares are fairly densely filled in. For the other eye, there's something there within the squares, but it's much fainter. Now, is this a symptom of the blood vessel effect? And is this something that's going to get worse over time for this right eye?
So my answer to that, probably not off the top of my head. When we're doing the Amsler grid test, we're really looking for that one thing, which is distortion. So the lines are bent. The lines can be not as clear, or they're a little shaded for other reasons that include the refraction, your glasses. A little bit of cataract causes loss of contrast sensitivity and those kinds of things. So that's affecting the shading. Those kinds of things could all be due to not macular degeneration. But the one thing that would be related to macular degeneration would be when the lines go all wavy. That's not going to happen because of your glasses or because of cataract, et cetera. That's more likely, that's going to be the retina. And that's when you pull the alarm bell, is when they go all wavy. And that can be sometimes due to even dry macular degeneration, can fool us, and we can get, oh, there's a little distortion there now, and you look and there's no wet macular degeneration. That does happen too. So there can be changes in the retina that are not due to an active condition, but they're stable. And that's where you have to kind of map it out and say, okay, this area that's been stable, it's been that way for months, that's just the way it is. Now you're looking for anything new. So, yeah, okay. Two more questions? Okay, I'm going to pass this next question off, I guarantee it, but let's see.
My doctor says that most likely my AMD is due to very high myopia. So my question would be, could we not change the shape of our eyeball for our offsprings who are maybe going to present with the same? I mean,
I know just the person to ask this question.
Genetic manipulation.
Dr. Els is our pediatric specialist as well. So.
That's a complicated question. Oh, sorry. Oh, but just to talk about definitions, when we talk about age-related macular degeneration and we talk about myopic degeneration, we think of them as separate categories. There is a certain overlap in how they're treated, and they both have abnormal blood vessel development or choroidal neovascular membranes, but by and large we talk about them separately, and they have different visual outcomes, different treatment strategies sometimes. So can we change, was the second part of that question, can we change the shape of our eyeball in young? Yeah, that's a really good question. So a nearsighted, myopic means nearsighted. So you have near sight. You have more, you have better vision at near distances, more difficult vision at greater distances. But in reality, all distances are affected, but that's the terminology. So in a nearsighted eye or a myopic eye, there can be two problems. The eyeball can be long, or the front of the eyeball can be steep. So can we change the length of the eyeball? It's determined by our genes, but we wonder whether or not some science does suggest that if we limit the amount of reading we do as children, and if we play more outside while wearing our sunglasses, could we change in a very, very small way the length of our eyeball? And then can we change the shape of the front of the eye? We don't know how to do that in a natural way, but some laser technology can change the shape of the front of the eye.
Everyone can hear me. Thank you very much for our doctors for sharing in this question and answer period.